Metabolic dysfunction-associated steatotic liver disease, or ASMLD, is notoriously complex. While broad polygenic risk factors explain many cases, this genetic background often masks highly penetrant rare variants that drive aggressive disease progression. Researchers compared 510 severe ASLD patients with 261 healthy controls. By isolating the severe cohort's genetic profile, they extracted a clear signal from the APOB gene. These severe patients carry these rare variants at nearly 14 times the control rate. These patients present a specific clinical contradiction. These variants induce a condition known as heterozygous hypobeta-lipoproteinemia. For the heart, this condition acts as a shield. It results in profoundly low circulating LDL cholesterol, protecting these patients from coronary artery disease throughout their lives. However, while their arteries remain clear, their liver histology shows catastrophic damage. Biopsies reveal advanced hepatocyte ballooning, severe fibrosis, and dangerous levels of lipid droplet retention. This creates a clear clinical marker for hepatologists. If a MASLD patient presents with unexpectedly low LDL cholesterol, dropping below 55 to 70 milligrams per deciliter without statin therapy, they require immediate APOB mutation screening. Understanding why this gene protects the heart while destroying the liver requires a look at the cellular mechanics of lipid export. Normally, the APOB gene provides the structural scaffold the liver needs to package and secrete very low-density lipoproteins, or VLDL, into the bloodstream. When a loss-of-function variant breaks the scaffold, VLDL secretion fails. Without a viable exit route, dense, oily lipid droplets rapidly accumulate inside the liver cell. As these intracellular lipid droplets expand, the resulting physical stress and lipotoxicity trigger a cascade of localized inflammation and fibrogenesis. This trapping mechanism is what starves the bloodstream of LDL cholesterol while simultaneously choking the liver tissue with fat. The genetic variant effectively trades coronary artery disease for liver disease, weaponizing the organ as an inescapable lipid sink that drives the progression toward cirrhosis. Not all APOB mutations carry the same risk. The severity of the disease is dictated by the precise location of the mutation along the gene sequence. This variability stems from tissue-specific mRNA editing. An enzyme alters the messenger RNA after transcription, changing the protein's final form depending on whether it is in the liver or the gut. This graph illustrates the resulting protein structure and its two distinct isoforms. APOB 100 is the full-length version produced in the liver, while APOB 48 is a truncated version made in the intestine. The critical dividing line sits at amino acid 2154. Mutations downstream of this line only disrupt the liver's APOB 100 isoform. However, mutations upstream trigger a premature stop codon that breaks both the hepatic APOB 100 and the intestinal APOB 48 isoform. Mapping this physical location allows us to predict whether a patient is facing isolated liver dysfunction or a systemic gut-liver failure. To see how these locations impact outcomes, researchers applied this protein map to population-scale data from over 500,000 individuals in the UK Biobank and the Million Veteran Program. The goal was to measure how the two mutation types, liver-only APOB 100 versus the dual isoform APOB 48 100, differed in their progression from MASLD to cirrhosis. This meta-analysis for cirrhosis shows both the upstream and downstream mutations drive a comparable, significant risk increase. Based on the odds ratios, these mutations appear equally destructive to the physical architecture of the liver. However, a stark divergence appears for hepatocellular carcinoma, or HCC. For liver-only APOB 100 mutations, the risk of developing liver cancer is elevated, but relatively modest. For gut and liver APOB 48/100 mutations, data shows an exponential spike in HCC risk, with odds ratios exceeding 10. Both mutations destroy liver tissue at the same rate, but the dual gut-liver mutation introduces an additional factor that triggers malignant cancer transformation. The data reveals a direct contradiction. The mutation that causes less lipid trapping in the liver actually results in more aggressive cancer. This forest plot of cardiovascular data proves the liver-only APOB 100 mutations trap lipids more effectively. In the coronary artery disease row, APOB 100 carriers, the green dots, show stronger heart protection because their livers hoard more fat than APOB 48/100 carriers, the orange dots. Yet despite this higher fat accumulation and similar levels of inflammation, these APOB 100 patients largely avoid hepatocellular carcinoma. This data forces a revision of the standard model. While hepatic lipid accumulation is required for HCC, it is clearly insufficient to drive aggressive carcinogenesis on its own. If the liver isn't the sole trigger, the search for the carcinogenic accelerant leads to the enterocytes of the intestine. The APOB 48/100 mutations cripple the intestine's ability to assemble and secrete chylomicrons. This failure leads to severe lipid malabsorption and a drastic inability to absorb fat-soluble antioxidants, specifically vitamin E. This malabsorption creates intense gut oxidative stress and microbiome dysbiosis, providing the signals that drive malignant transformation. These toxic signals travel via the portal vein to a liver already choked with fat, acting as the final biological match that ignites carcinogenesis. This confirms that treating advanced MAS LSD as a localized liver disease ignores the systemic triggers of cancer. APOB genetic screening allows clinicians to move beyond a simple cirrhosis diagnosis and map a patient's exact isoform-specific trajectory toward liver cancer.